Yep, you can.
Okay, fantastic. And can everybody see my slide?
You can.
Okay, perfect. Let's get started. All right. So this is the health policy elective, advanced health policy elective. And so I was tasked with introducing public health, public policy, and the politics that go along with it because you can't have public health without politics. As a good place to start, I am going to start with a survey that was done by the Commonwealth Fund in 2014. So it's a little old, but the data hasn't changed a whole lot, and and it actually has never been repeated, probably for political reasons. But this is a summary of the study that was done. Is 11 countries. The United States is over here on the right-hand side, and it looked at different matrices for quality of healthcare delivery in each one of these first world countries. As you can see in the first row there, hopefully you can all see that, the United States ranked 11 out of 11. Now, I know that for me, I go to the hospital every day. I'm in the hospital, and I think we deliver very good care. And everybody I know cares a lot about their patients and works very hard to deliver the best care that they can. Uh, but what we're talking about here is we're talking about something in terms of the entire country and how we deliver healthcare services. And what they found was we were pretty good. We ranked third in a delivery of healthcare, effective healthcare, which I would agree with. But in terms of access to healthcare, we came out 11th out of 11th because in the United States, unlike many other first world countries, we have barriers to healthcare, notably the cost of healthcare. We also ranked 11th out of 11th in terms of efficiency. That is, how well do we deliver the services that we have, that patients need and want. But we're very inefficient because of our fee for service. So you might go see a family practice doc, and they say, well, you need to go see a specialist. They may take an X-ray and then send you off to the specialist. The specialist comes to see, you go to see the specialist. The specialist takes another X-ray because they never got the X-ray from the primary care physician. Might then refer you on to a surgeon who might then repeat it again. So our system is very inefficient because it's driven by finance, and each time one of those X-rays are being done, somebody makes some money from it. We rank 11th out of 11th for equity. That is, how evenly spread is the delivery of our healthcare services. We don't have universal health insurance, so then that means in order to get good health services, you need to be insured. And not everybody in the United States is insured. So then that means that there are people out there that do not get access to health care, and therefore the distribution of our healthcare services are not fairly distributed. And then also we ranked 11th out of 11th in terms of healthy lives. That is, how much of our resources do we put towards making sure that our population is healthy in terms of preventive care and other things. Our whole healthcare system is driven by finance, and therefore we get paid by fixing things and not for preventing things. Now, the picture is changing slowly but surely. It is changing, but compared to other countries, we're certainly lagging behind. So let's take a look at some of these a little bit more closely. Oh, yes, and also we are doing that at almost twice the cost of every other country per capita. So that last line is health expenditures per capita. This was 10 years ago, but the numbers have only gotten worse. That we were spending 8,500 per capita in the United States for healthcare, whereas other countries were somewhere around 4,000. So we are spending more per capita on healthcare and delivering less quality. Well, let's look at the quality of healthcare in the United States. This is an interesting graph. Again, it's fairly old, but the data hasn't changed a whole lot. And I kind of like it because it actually gives us a lot of information. On the x-axis, we have healthcare expenditures per capita. On the y-axis, we have deaths per 1,000 live births. And then we have each one of the countries, the size of the circle is actually their gross domestic product. So what we have is we have a nice regression curve, which is in red, that shows that as we spend more on healthcare, the infant mortality goes down. So that's a pretty good measure of the health of a country and how effective their healthcare is. Well, the United States sits over here. It spends more than any other country on healthcare, has a very large GDP, but its healthcare services, infant mortality is greater than that of Hungary, Poland, and the Slovak Republic. In 2019, the infant mortality rate per 1,000 live births was 5.748. And the good news is that's a 1% decline from 2018. So from 2018 to 2019, the infant mortality rate went down by about 1%. And also good news, from 2017 to 2018, the infant mortality rate went down by about 0.5%. And also, we deliver very good care. So it's not that people are not getting the care that they need, but it's usually our infant mortality rate is more related to congenital birth defects and also things that happen during gestation. For example, malnutrition, drug abuse, physical abuse. Those sorts of things drive our infant mortality rate up. But also, the infant mortality rate is not equally distributed across the population. African Americans, Native Americans, and Hispanic American parents are far more likely than European Americans to lose a baby at birth here in the United States. In fact, the infant death rate in the first year for African American women is double that of European American women. Let's take a look at maternal mortality. This is deaths per 100,000 live births. In the United States, we far exceed many of the other first world countries. This is a different study, so it actually has some Asian countries in this study as well. Our maternal mortality rate is unacceptably high. 17.4 deaths per 100,000 live births exceeds all other developed countries. And in fact, as other countries' maternal mortality rates are declining, in the United States, it's either the same or has been increasing for some of our groups. And again, there are stark and unacceptable racial and ethnic disparities that persist. Even though the average is 17.4, the maternal mortality rate for African Americans is 37.1. And also, it looks like there was another study that was done that shows that the maternal death rate among Native American mothers is double that of European Americans. What about life expectancy in the United States? So this is another interesting graph. On the x-axis, we have health spending per capita. And then on the y-axis, we have life expectancy. And then many of the countries are graphed. And you can see that if you spend more on healthcare per capita, that you really do see quite an improvement in life expectancy. And initially, it's really quite dramatic. And then the more that you spend, it tends to level out a little bit. The United States, once again, is an outlier. The United States spends more than every other country on healthcare, and yet its life expectancy at birth is on the level of Chile, the Czech Republic, Estonia. Compared to other first world countries, you can see that from 1980 to 2015, the United States has been falling off on its life expectancy. In 1980 is right there in the middle of the pack with other first world countries. But something's happened in the last 30 years or so, or 40 years or so, where the United States has really been falling off. While all other first world countries continue to see improvements in life expectancy, the United States is leveling out. And then starting in 2016, for the very first time, we actually saw a decrease in life expectancy in the United States. People largely attributed that to the opioid epidemic that continues to rage here in the United States. Adult obesity is a key risk factor for chronic conditions such as diabetes, hypertension, and other cardiovascular diseases, as well as cancer. The United States has the highest obesity rate among the first world countries that were studied. It's 2 times higher than the average of all these countries, and approximately 4 times higher than that of Switzerland and Norway. But it's actually interesting if you look at this. Overall, the obesity rates were highest in the English-speaking countries. So you have the United States, New Zealand, Australia, and the UK and Canada where the obesity rates were highest. Obesity, probably unhealthy living environments, less regulated food and agriculture industries, as well as socioeconomic and behavioral factors all contribute to it. Again, there are racial disparities in obesity. About 50% of African Americans are obese, compared to 70% of Asian Americans. So the distribution of obesity is not equal across the country, but rather there are socioeconomic and racial disparities that can be seen in this. What about deaths amenable to healthcare? What are deaths amenable to healthcare? Well, those are the deaths that would not occur if the person had gotten timely preventive or medical care. There was a study that was done in 2002-2003 with 8 different countries, and the United States had the highest death rate per 100,000 population, deaths amenable to healthcare. They repeated the study in 2006 and 2007, and again, there were improvements all the way across the board in terms of deaths that were amenable to healthcare. But you can see that the United States continues to lead the pack in terms of deaths amenable to healthcare. And this primarily is a result of lack of insurance on the part of currently about 10% of our population. What about suicides? Deaths per 100,000 population. The United States has the highest suicide rate among comparable first world countries at 13.9 per 100,000. And this reflects the higher stress rates that people have in the United States, as well as significant socioeconomic disparities. We do some things that pretty well. Breast cancer screening. We have one of the highest rates of screening for breast cancer among women between the ages of 50 and 69. So we've done very, very well in that regard. We're also very good with respect to breast cancer 5-year survival rates. We have seen our survival rates for breast cancer increase significantly over the last 10 years or so. Although, again, if you dig deep into this data, you'll see that there are racial disparities that continue to persist. African American women, the survival rate is 81% compared to European American women, which is 92%. African American women tend to be diagnosed later and to have poor stage-specific survival. And it's thought, again, to be socioeconomic factors and lack of access to proper health care. Okay, another public health emergency that we've had, that we've been living through for the past year and a half, has been the coronavirus pandemic. We probably all know most of this data, so I'm not going to dwell on it. Here we are. This is a cumulative confirmed COVID-19 cases that have been normalized to the population, and you can see that the United States cumulatively has had more than most other first world countries. We don't really know third world country data simply because they don't have, they're not as efficient in tracking it as we are. In terms of cumulative COVID-19 deaths per million people, we're actually second. The United Kingdom is first, but we're right up there. Perhaps if we had taken earlier intervention, their death rate probably would not be so high. So this was a failure on the part of the Public Health Administration, the Federal Public Health Administration, and politics played a very large role in these deaths. Well, we're actually doing pretty well in terms of vaccinations, though. Israel leads the world in those that have received at least one dose of the COVID-19 vaccine, followed by the United Kingdom and Chile, and then the United States. So we're catching up, and this is good news, and this, I think, we can count as a public health success. And being able to roll out the vaccine, and first of all, being able to develop the vaccine, roll out the vaccine, and then have the infrastructure to be able to ensure that it's available to everybody here in the United States. The opioid pandemic has overshadowed, the COVID-19 pandemic has overshadowed the opioid epidemic that has been going on for a number of years in the United States. And it is something that really has devastated our population under the age of 50. And it continues to go on, and we continue to see people suffer from the opioid epidemic, which is largely thought to be iatrogenic in nature. It's the leading cause of death for Americans under the age of 50. COVID-19 may have overtaken that, but once COVID-19 has passed, this will continue to be the leading cause of death. In fact, people think that because of the isolation of COVID-19 that we will actually see, once the data is in, that we'll actually see that more Americans have died of opioid overdoses in 2019, 2020, 2021 than previously. It began in the 1990s, really took off in the last 10 years or so, and continues to really be devastating. We know there's iatrogenic in its making. Of course, we all know about Purdue and Purdue being sued for OxyContin. But if you take a look at this graph, you can see that sometime in the 90s, that we started in the purple, we as doctors started prescribing more and more opioids. And then as time went on, there was those that could not get enough of the opioids from their doctors started taking heroin. That's in the orange, and then the manufacturers, clandestine pharmaceutical manufacturers in Asia started to produce synthetic fentanyl, which was easier to transport and didn't require a growth cycles like opium does, and start to send that here into the United States. And then the use of synthetic opioids, fentanyl, carfentanil, a bunch of others, started to take off and has been a leading cause of death here in the United States. The problem with it is that it's a white powder. You don't know if it's been cut with talcum or been cut with sugar or anything else. You don't know what the potency of it is. So you may have bought it from one person or the same person who had cut it and then decide to sell you something that's totally pure. They shoot it up and they end up dying. So it's been pretty devastating. Institutional racism that's been with this country since the founding fathers has had a devastating impact on public health, and it's although it is an emergency that's been going on for many years. Because of a long history of institutional racism, there is entrenched economic and health disparities. And after many years, African Americans are more likely to be poor. African Americans are more likely to suffer discrimination, more likely to suffer violence on a daily basis. They're more likely to be wrongly incarcerated. They're more likely to die from trauma. African Americans are more likely to work in industries that expose them to chemicals that are bad for their health. They're more likely to live in crowded conditions that put them at risk for communicable diseases, particularly the COVID-19. And they're more likely to live in areas of the United States that have less access to health care. And as a result, African Americans are more likely to have chronic medical conditions and are more likely to present with comorbidities due to timely health care and lack of nutritional education. The COVID-19 pandemic is an example of how the institutional racism has resulted in communities of color being disproportionately burdened by the disease. In Chicago, African Americans make up 30% of the population, but account for 68% of the COVID-19 deaths. So institutional racism is a moral, it's an economic, and it's a public health emergency. Okay, let's move on to affordability. Affordability of healthcare. Okay, so the Commonwealth Fund, this is from that first slide that I showed you. Part of it was looking at the efficiency of the healthcare system, and they did a survey of patients and asked them how many of them spent a lot of time on paperwork or on disputes related to medical bills. And the United States, like many other matrices, came out first in a bad way. That is that there are disputes and confusion and difficulty coordinating care and disputes related to medical billing. We also allocate our healthcare spending in a very unusual way. This is an interesting graph. If you look at the x-axis, you see that that's a share of people in the United States, and on the y-axis is a share of healthcare spending. So all the way to the right and all the way to the top, you're spending 100% of healthcare resources on 100% of the people. Now, if you look at that dark blue line, that thin sliver of dark blue line, all the way to the right, you can see on the y-axis this goes from 100% down to 80%. And what that is telling us is that we are spending fully 20% of our healthcare resources on 1% of our population. And then if you look at the light blue line that goes from 80% down to 50%, that's indicating that we're spending fully 50% of our healthcare resources on 5% of the population, which means that we're spending the other 50% of our healthcare resources on 95% of the population. So the distribution, because we love high tech and we love all the things that we can do and how we can keep people alive for ages, even though maybe they don't want to be, that we actually ended up spending so much more, 50% of our entire healthcare resources on 5% of our population. And perhaps if we concentrate more on preventive care and other things and keeping people healthy and letting people die with dignity, that perhaps we could shift this graph. But the cost of healthcare continues to go up, partly because all the technology that we have, that we've fallen in love with. You can see from 2000 to 2020, the premiums have risen for a family of four, have risen from about $6,500 a year to $20,576 per year. So that's a rise of annual premiums for a family of four of over 320%. And if we take a look at it a slightly different way, we can see that this is from the last 10 years or so, 2010 to 2020. If you look at that gray line, the overall inflation rate over those 10 years was about 19%. Workers' wages actually increased by 27%. So all other factors being equal, workers would have taken home more money at the end of the day after those 10 years and had more to spend on whatever they want, vacations or other would be disposable income. But unfortunately, family premiums rose by 55%, and the deductibles attributed to those premiums rose by 111%, which ate up any gains that those workers would have made from having an income that was higher than rate inflation. So, but it's not just the families that are suffering, it is the employers of the families that are also suffering. So this is from 1999 to 2020. What you see is the rise in the healthcare premiums over that time. Now, the orange is what the family of four saw, and the blue is what the employer saw. So the employer actually was absorbing more and more of the brunt of the increased healthcare increased cost of premiums But the family of four also saw quite a dramatic increase in their personal spending, but the employers also saw this as a larger and larger portion of their own balance sheets. So, out-of-pocket expenses. So, what are out-of-pocket expenses? Oftentimes, in health insurance, you pay a premium, but then you have to pay deductibles or some other out-of-pocket expenses up to a certain amount. So, for example, a family of four might have health insurance that costs them $6,000 or $7,000 a year, but their deductible might be $6,000 a year as well. So they will be paying, and there are many different flavors of this, but basically they would be paying that $6,000 before their health insurance kicks in. Obviously, sometimes there's deductibles where you pay a certain amount, then your health insurance pays a certain amount, but until you reach your entire out-of-pocket expense, your health insurance doesn't pay 100%. After you reach that, it does, but it can be pretty high. So on average, Americans incurred about $1,000 of out-of-pocket expenses for healthcare in 2018, and it's thought that it will go up over the next couple of years. And as a result of these increasing costs, what we're seeing more and more people delaying going to see the doctor and delaying or foregoing healthcare entirely. And in this study that was done in 2016, which was after Obamacare had kicked in, still about a third of the people that were surveyed said that they had delayed to see their doctor or foregone some kind of health care entirely because of cost. Now that's a problem, because then that means that these patients are going to be coming in sicker than they would otherwise, and therefore would require more healthcare resources than if they had been taken care of right out of the gates. Let's talk about the number of uninsured. So in 2010, before the Affordable Care Act was passed, there were about 50 million Americans in the United States that lacked health insurance. And that's equal to the combined populations of Sweden, Austria, Switzerland, Denmark, Finland, Norway, and Ireland. It's a large number. There are 50 million people in the United States who were without health insurance. And then Obamacare came along, which we are very grateful for. You can see that the first number, 47 million, that was the number of uninsured people at the time that President Obama was elected. By the time that the Patient Protection Affordable Care Act, also known as Obamacare, passed, there were 52 million people that were uninsured. And then it took a couple of years for it to kick in. And by the time the health exchanges rolled out, there were 54 million people that were uninsured. And then we saw a dramatic drop in the number of uninsured as Obamacare kicked in. It fell down to 42 million people. Now, that's great, right? But the problem is that it's still lags far, far behind what all the other first world countries are in terms of insuring their population. As you can see, here are a dozen or so first world countries, and they all insure their population 99 to 100%. And the reason for that is almost all of them have universal health care coverage. The United States is an outlier. It now currently insures about 90 to 91% of its population, which means that there are still, even after Obamacare, there are still some 30 million Americans that lack health insurance. But there's more. Now let's talk about national healthcare spending and how national healthcare spending is an even bigger problem than anything we've talked about so far. So healthcare spending in the United States has gone up and up. Back in 1972, it was around the other comparable first world countries, but somewhere since that time, it has grown larger and larger and larger part of our GDP. GDP is gross domestic product, which is all the goods and services that are produced here in the United States. And if you put a price tag on that, that is GDP. So we are spending somewhere around 17% of our GDP on healthcare versus about 10% for other first world countries. Now we could say, oh, that doesn't really matter because we're a rich country, we produce all these goods and services, why shouldn't we be spending more? Well, the problem is if you actually normalize it and do compare per capita healthcare spending versus per capita GDP, you can see the United States is still very much of an outlier. It's spending much more of its GDP on healthcare than perhaps it ought to, even though it produces lots of goods and services. And one of the biggest payers for healthcare is the federal government, right? They pay Medicare, they pay portions of Medicaid, they pay CHIP, they pay a bunch of other things. They also pay Social Security. So they every year they put together a budget. This is the most recent budget from 2019. It's a $4.4 trillion budget, and this is how they spent it. They spent about 2% on transportation, so that's all the highways in the United States. Those are all the bridges. Those are all the everything to do with transportation and the regulation of the trucking industry. They spent about 2% on K through 12 education, and about 6% on everything else. They spend 8% on interest. That is, whenever, just like if you borrow money for student loans, you're going to pay interest on it, right? So when the federal government borrows money, they are going to have to pay interest on that. They spent about 17% on national defense. Those are all the aircraft carriers, all the fighter jet pilots, all the jets, the bases around the world, all the military personnel, about 17%. 16% is sort of the whole federal government, the judiciary, and running the judiciary and services for that. And then they're spending about 50% on entitlements. Now, we call them entitlements is because they can't cut that even if they wanted to. It's Medicare, Medicaid, and Social Security. That is, when I get my paycheck every month, there's a certain amount that's taken out for Medicare, because when I turn 65, I'm entitled to that, to those services, those Medicare services, because I paid into it throughout my working life. Same with Social Security. Every month I get a paycheck and they take a certain amount out for Social Security, and when I turn 65, I am eligible to receive Social Security benefits. So we call those entitlements because they're entitled. The only problem is that as I pay in, the federal government right now is paying it out. It's not like there's a savings account somewhere for me. They're paying it out as I pay it in. And so they are obligated to pay these entitlements, and that's a full 50% of the budget. So just to give you an idea of what this means, and let me see if I can get this to run, and you let me know if you can't hear this. Just to give you a sense of how big the budget is and how we're spending it, let me just play this little clip.
Recently, President Obama made news by announcing that his team would find $100 million worth of federal spending that they can cut from the budget. Some people are saying that the president is just taking a number that sounds big so that it'll look like he's doing something about federal spending. We humans have a problem with big numbers. We hear that the president is taking $100 million out of a $3.5 trillion budget, but what we understand is the president is taking a big pile of money out of a bigger pile of money. We don't get the concept of scale very well when we're dealing with that kind of money. And I think we can understand better. Let's stack 5 pennies together and say that this represents $2 billion. This is the federal budget, about $100 in pennies. Well, just a little under 90 after I take out the leafy pennies and the ones from my birth year and the pennies with the Queen of England on them. I think it's a Canadian conspiracy to ruin our monetary system. To the left of the white line is mandatory spending. Before we can fix a single road or build a bridge or pay a soldier, we have to spend this money. It's mainly Social Security, Medicare, Medicaid. President Obama couldn't cut spending from there even if he wanted to. To the right of the white line is the only part of the budget he can reduce. To the left of the blue line is money we have. To the right of the blue line is money we don't have, so we have to borrow it. We'd obviously like to reduce the number of pennies on the right side of the blue line if we can. Here's what President Obama says he's going to do. We'll just grab that penny there. Then we take 3/4 of our penny, and we put it back on the budget. And the president's team is going to take 90 days to find some way to take this out of that. And suddenly, $100 million doesn't seem as big to me as when he said it in the press conference.
Okay, so the thing is, it's a lot of money, and a whole portion of that money is entitlements that can't be cut, right? because it's Medicare, Medicaid, Social Security. Now, the problem is that over time, we are spending more and more money. And here is projected spending from 1980 to 2025. And what we are seeing, and this graph was put out by the Centers for Medicare and Medicaid Services in March of 2020. It's accurate. Right now, we're somewhere around here, about 17, 18%. 2019 is 17.7%. We'll get some other data soon in the next couple months as to where it is, but we're on track. This is right. So projected as a percentage of the GDP, we are starting to spend more and more on healthcare spending, right? And that means we're spending more and more on Medicare and Medicaid. And then we have another problem. Not only are we spending more as a percentage of our GDP, but we're actually starting to see that the more people are qualifying for Medicare and they're also living longer. Right now, we're going through this where the baby boomers are starting to retire. A big bolus of people that were born after the Second World War, they are now starting to retire. And as people live longer and longer, they are all going to be on the Medicare rolls. And so Medicare enrollments is going up, and this is right on. By 2035, we should have 86 million Medicare enrollees. Back in 1970, so Medicare was formed in 1965, and people weren't living so long. They were still smoking cigarettes back then. They weren't living so long, and there were only 20 million enrolled in 1970. Now we're going to have 86 million people enrolled in 2035. And so healthcare spending is going to go up. And we know that because of the disproportionate way that we spend on healthcare, that those that are 85 years and older are going to get a disproportionate amount of healthcare spending. So it's not the people between 18 and 65 that we're worried about. We're worried about the spending between 65 and 85 or 90. And so we are spending more and more money on these older people. There are more and more of the older people, and this is all accruing to the federal government. So federal spending is anticipated to go up, and we will be spending over $1 trillion out of what is currently about 4.5 trillion, not including the pandemic stuff, but we are spending about $4.5 trillion in a regular budget, and a full $1 trillion of that in the next year or two will be for Medicare spending alone. And so if you look at healthcare spending as a percentage of the GDP, the federal healthcare spending, you can see that Medicare is going to make up a very large portion of it, as well as Medicaid and CHIP and other federal programs that are paid for. So the problem is, on the left-hand side, you see that the number of beneficiaries in Medicare is going up and up and up and up, right? People are living longer, the baby boomers are coming through, and it's going up. But the number of workers per beneficiary is actually going down. So every month I pay into Medicare and they spend it, right? But now the problem is that once I'm retired and all these other people are retired, the people that will be paying into Medicare is going to be a lot less. So that's the same with Social Security as well. So this is actually the surplus and deficit in Social Security, and you can see starting with the economic crisis in around 2009, 2010, the federal government started dipping into the Social Security pools and actually spending some of that. Now we're in 2020. They have a big deficit. They're pulling more money out of Social Security in order to pay their bills, and we are going to see the Social Security Trust Fund depleted by about 2035. And this was produced in April 2020 by the Social Security Administration, and so it doesn't account for all this additional borrowing that's been taking place recently for the COVID pandemic. And so if you are spending more and more on Medicare and Social Security, and you've already been dipping into it, but then there are more people that are qualifying, then you're going to have to take the general income tax that we pay every year, the general tax revenue that the country gets from everybody filling out their 1040s and take a larger and larger portion of that to pay these mandatory expenses. So to pay Medicare, Medicaid, Social Security, right? So they're thinking that by 2030, it's going to be about 50% of all the general income tax revenue coming into the federal government is going to go to pay for Medicare and Medicaid. And we knew about this. We knew about this, 10, 12 years ago. I mean, this was well known. In fact, on June 9th, 2009, then President Barack Obama convened a joint session of Congress to talk about this very issue. And this is what he said. Let's see if I can get this started.
Finally, our healthcare system is placing an unsustainable burden on taxpayers. When healthcare costs grow at the rate they have, it puts greater pressure on programs like Medicare and Medicaid. If we do nothing to slow these skyrocketing costs, we will eventually be spending more on Medicare and Medicaid than every other government program combined. Put simply, our healthcare problem is our deficit problem. Nothing else even comes close. Nothing else. Now, these are the facts. Nobody disputes them. We know we must reform this system. The question is how.
Okay, so we are in a situation where we're spending more, we're getting more and more Medicare beneficiaries, we're spending more and more money on Medicare, and we're dipping into all these other sources like Social Security, and there's less money coming in. So the only solution when you have a $4.4 trillion budget and you're only bringing in a certain amount of money is to borrow. And so that's what the federal government's been doing. And as of a couple of days ago, this is what the United States has borrowed so far. This is public debt. It gets very, very complicated, but this is the public debt that you can go out and you can lend the federal government money, and that'll be part of their debt, and they'll pay you interest on it. Right now, it's $28 trillion, and that is about $85,000 for every single man, woman, and child in America. And this is the way the debt looks. So the debt is kind of a more recent thing. It hasn't been something that we've done forever. You can see since the beginning of the country, we actually, in the 1840s, we were actually had a balanced budget and we had no debt. Borrowed some money for the Civil War, that was reasonable, paid it back. Borrowed money for the World War I, paid most of that back, but then hit the Great Depression. Borrowed money for the Second World War, paid a lot of that back. Then we hit the Great Recession of 2008, 2009. Borrowed money, never paid it back. Then we hit the pandemic, which is like a little blip here. Borrowed, no intention to pay that back. And we'll get through the pandemic. But as you can see, the pandemic is just a bump in the road. The anticipated spending by the federal government looking down the road, independent of the pandemic, is going to be tremendous. And our debt is going to go up, and they estimate that by the year 2051, it'll be double that of our GDP. So what does that mean? Well, what we have is we have the amount that the federal government collects and the amount that it spends. The difference between what it collects and it spends is the deficit. And the cumulative deficit is the debt. And they tried to stay kind of within some kind of bounds. They were the federal government was always borrowing money, but was kind of doing it in kind of a fairly responsible way. And then we hit the financial crisis, and we hit the now we're in the midst of a pandemic. And now what people are talking about, nobody knows really, but what people are talking about is maybe debt doesn't matter. Everybody says, well, it's like, borrowing for education. You got to pay it back someday, or borrowing on a house. You got to pay it back someday. But there are other economists out there that say maybe it really doesn't matter. I mean, you don't want to be borrowing money just simply to, buy a nice car or something. But if you're borrowing money in order to make your business grow larger, then maybe it's worthwhile. And so there's this idea that's floating around now among members of Congress and the public is that it's okay to borrow all this money because we're putting it into infrastructure. We're putting it into, creating jobs and all this other things that will increase our GDP. And so maybe it doesn't matter if we borrow trillions and trillions of dollars. The reality is that nobody really knows. And so we're an experiment in progress. But what we do know is that as mandatory spending on Social Security, Medicare, and Medicaid goes up and up and up, which it is, and occupying a larger and larger portion of the federal budget, then all the other discretionary spending is going to go down. So K through 12 education, the military, the judiciary, all those, transportation, all of those are going to start to get squeezed as we spend more and more money on Medicare and Medicaid. And that is a problem. And then any deficit that we have, we're going to borrow it. And remember, one of the parts of the federal budget is to pay interest on that debt. And so that is a number that is going to grow as well. And right now we are enjoying historic low interest rates, which is the reason real estate's going through the market, which is great. And the government is borrowing. But as interest rates go up, then the amount of interest payments that the federal government is going to have to pay is going to go up as well. And so it's estimated by the Congressional Budget Office that our interest costs are going to skyrocket. And the consequence of that, obviously, is this. So if you estimate, the red line is the amount of money that's brought in to the federal government through all the taxing, corporate taxes, individual income tax, all that, is about 18% of the gross domestic product. Then you have at the bottom there, the dark blue is Medicare, then the light blue is Social Security, and then the dark blue again is Medicaid and everything else. And then the yellow or orange is interest payments. So as you can see, as interest rates go, as the government borrows more and interest rates start to go up, at some point there's going to be an inflection point at which the amount of revenue is going to equal the amount that's being paid for Medicare, Medicaid, Social Security, and interest payments, right? That means that there's no discretionary money for anything else. No discretionary money for education, transportation, the military, anything. If we want to spend any money on that, we will have to borrow all of that money to pay for our discretionary expenses. Of course, it's not as simple as that, but this is the concept. So that is it. And hopefully that gives you a good introduction to what we think about in public health, what the issues are in public health in terms of maintaining the public health, and why the finances are becoming increasingly more important, and why we have to figure out ways to control that. What I'm going to talk about tomorrow is the Affordable Care Act and how that was designed to help decrease the rate of rise of healthcare expenditures, and whether it did or didn't do that.
Now, I hope you're not too overwhelmed after hearing a lot of the pitfalls and difficulties of our system. That's exactly what we're here for in this elective, to make sure you understand the issues at hand and the ways in which we're going to go about fixing them. We're going to offer some time for Q&A with the fantastic Dr. Kelly right now. Feel free to unmute yourself or drop them in the chat. I should also note that feedback for this session is now open. It's the same Poll Everywhere link that we've been using before. And we invite you to fill out feedback. This is how we make sessions better. This is how we give our fantastic session leaders their props. So head to this link, pollev.com/AHPE2021 to fill out feedback for the sessions. Any questions though?
I haven't checked the chat. Is there anything in the chat?
No, there was some good conversation, not so much questions as much as they were comments. Really comments around the issues around underinsurance and how those that are uninsured can in some ways be pulled into the category in terms of out of pocket responsibility with those who are uninsured. We certainly saw some conversation, at least in my kind of direct message chat, around the topics around institutionalized and structural racism and how that affects a lot of the disparities that you outlined today. So we appreciate those comments and we appreciate that feedback from folks. But Dr. Kelly is here to answer any questions that you have.
Well, Dr. Kelly, thanks for that talk and introduction, and also terrifying me about the future. I guess wanted a little bit of commentary, if you can offer it, on just where's the discussion now about some of the most important leverage points to start to once again try to bend the cost curve? Like, where's the discussion in the last even 5 years about some of the most promising opportunities to start containing costs?
Well, I think that the Affordable Care Act really tried to bend that cost curve. So when we talk about the cost curve, we're talking about we have a rate of rise of healthcare costs, and we know that it's been predicted for a number of years, and we're right on that curve. And so we like to think about ideas that will what we call bend that cost curve, actually kind of bring it down. So over time, we're not spending as much as quickly as we were. And so there were a lot of ideas that were put forward in the Affordable Care Act that have been tried. Things like accountable care organizations, paying for primary care residents, boosting their salaries so more people would go into primary care and there wouldn't be such a disparity between specialists and primary care. There were ideas of how to just make things much more efficient, how to keep people from having to go into nursing homes and maybe be taken care of at home, how to keep people healthy by labeling foods. There are all sorts of ideas in there. And some of them have panned out a little bit, and some of them kind of didn't go anywhere. In terms of where we are now, I think that there aren't any. I haven't seen any major new developments that are being debated in Congress to really try to bend that cost curve. So it's worrisome, but I think that it will come to the fore again, and I think that we will see people putting forward some very good proposals. But so far, I think that we have bent the cost curve since 2014, but we're still facing some real challenges financially.
A question that I always have in hearing you having given this talk before is, how do you not become overwhelmed at the gravity and size of these issues? You laid out issues from the federal budget down to more individual community-based disparities. I wonder how you, as an academic and as a provider, as a legal professional, stay hopeful in hearing about where we are.
Well, I do think that people in Congress, although they say stupid things, are actually pretty smart. And it's not just the elected officials, but there's an entire staff that supports each one of these elected officials. And they are thoughtful, they're smart, they're articulate, they're well educated, they think hard about these issues. And but we have a clash of ideologies, we have a clash of socioeconomic ideas. So it's more like 2 steps forward, 1 step back. I mean, we've known about this for a number of years. Small steps have been taken. I think larger steps will be taken. And once it becomes something that nobody can ignore, I think that they will do something. So I am hopeful, and we've had progress. The disparities exist, but there have been many. There's been a lot of legislation on the opioid epidemic. We finally got our act together with respect to the COVID-19 pandemic. We are addressing, although slowly but inexorably, I think we're addressing socioeconomic and racial disparities here in the United States. It's a slow grind, but I think because of who we are, I think we'll end up in the right place.
Zoe asked the question, how do you think the lobbying presence in the United States affects some of this high cost of healthcare that we see in the United States?
Oh,
I should mention, Zoe, that we do have a full session on lobbying as a practice and its influence too, on Thursday, the 22nd. So definitely join us for that. But Dr. Kelly.
Yeah, I think lobbying is probably one of the most insidious and destructive elements of our democracy. It is something that I don't think was ever really anticipated by our founding fathers, and I think that the fact that entities with big money can influence legislation to their benefit erodes away our democracy. And so I think it's one of the biggest dangers that we that confront us. And I don't know exactly how to deal with it, but it's a real problem. In fact, it's been known for a while that what happens in terms of bills is that these think tanks and these lobbyists who are part of larger law firms, and they're just not like individuals, they're like huge entities, will actually draft legislation that they want, and then they will go and shop it around to members of Congress and find somebody to support their bill. And then, if it's something that would cause a public upcry, they would actually, slip it into something else that really, so it wouldn't get a whole lot of attention. But yes, I mean, they've been doing that for years, and it's really destructive.
Now, there are lobbies that exist and political action committees that exist on behalf of patients, on behalf of providers. And so I think that would be the big caveat to Dr. Kelly's statement. We'll learn about how physicians can leverage legislative advocacy days and lobby days on the Hill to call for things that are needed for us as physicians, as providers, and as patients. But I think the point that was made here is really well taken. The idea that financial interests can take advantage or take precedence over the needs of actual people is what becomes problematic. And that's how we see ballooning of costs to the consumer, to the patient. Absolutely.
Yeah. So yes, I mean, it cuts both ways, right? So you can lobby for good, but money talks, and so those with the most money seem to be heard more than those that don't. So I will. Yeah, I guess I'm running out. I was going to just tell you a story of how lobbying has affected healthcare dramatically, but it looks like we're at 2:45. I think I have until 2:40, 2:50 or what?
50.
Oh, okay. So I have 3 minutes. So I'll tell you this story quickly. So anyway, there was a man. This was before Obamacare and everything. It was during the Bush Jr. administration. Billy Talzig was head of the Ways and Means Committee in Congress, and they're the ones that deal with Medicare and Medicaid. And so anyway, there is this thing called the prescription drug benefit. So almost everything that is done is somehow supported by something, right? So Medicare is supported by all of our contributions, Social Security and everything. Well, anyway, the pharmaceutical industry came up with this great idea. Why don't we provide a prescription drug benefit? And so they shopped it around. They found Billy Talzig, and he pushed it through. And Bush didn't veto a single thing during his entire administration. So it got to his desk and it got signed. Well, the prescription drug benefit for seniors is completely unfunded, which means that they just said, we're going to pay for all this stuff. And suddenly it became another debit on the federal balance sheet. There's nothing, nobody pays into it to make it happen, right? So which was hugely profitable for the pharmaceutical industry. And they were behind pushing this prescription drug benefit that then got signed into law. And as a reward, when Billy Tauzik retired from Congress, he became president of PhRMA, which is the lobbying arm of the pharmaceutical industry. And then he was also responsible for helping PhRMA cut a deal during the negotiations for Obamacare. Basically, he went to the people that were putting together Obamacare and said, "Look, we've got a war chest of about $50 million, and either we're going to spend it in support of Obamacare, advertising in support of Obamacare, or we're going to spend it fighting Obamacare. And so we want to cut a deal." And what the deal that they cut was that the pharmaceutical industry over 10 years would pay $50 billion to the federal government. And then after 10 years that they would be unregulated, which is one of the reasons that we have seen pharmaceutical costs rise and rise. There's other reasons, but one of the reasons that it hasn't been regulated is because of the deal that was cut in 2009 when Obamacare was being put together. That in exchange for $50 billion, that they would not be as tightly regulated. So yeah. So
Yeah,
that's
so if
that's
how lobbying can be insidious, right?
Yes.
Absolutely. A last question from Sarah asking, do you think that our move towards virtual primary care and digital health can potentially decrease some of these costs?
Yes, absolutely. When you think about it, I mean, just in so many different ways. Somebody who is getting sick needs to go see their doctor. They need to take a day off from work. They need to drive there. They need to park. They need to pay parking. They need to go wait all day in the primary care office, see their doctor, go drive to get their prescription, all this, and then drive home, take whatever time off from work, all this. And all that infrastructure, and then in the doctor's office, they have to have all the front desk staff to check them in, check them out, all this stuff. By going virtual, you can actually cut down on a lot of that cost, right? That maybe it might be more efficient for the doctor to be able to, instead of running all over the place, to see people and to have them checked in and wait and all this, that they can actually wait in the comfort of their own home or actually work while they're waiting and then be able to be seen. The disadvantage is that you really can't do a physical exam. And so there's a real danger that you might miss something. But I do think that it will drive efficiencies and will allow more patients to be seen and perhaps at less cost to the entire system.
Well, fantastic. I think we heard a couple different really interesting perspectives from Dr. Kelly. Thank you for being with us. We're excited to see him back tomorrow to talk about the Affordable Care Act and what the ACA actually is. We invite you to give us feedback on this session, including what we talked about around Q&A. It's just pollev.com/AHPE. Join us back here in 9 minutes to talk about the Veterans Health Administration. And thanks again, Dr. Kelly.
Oh, you're welcome. Thanks for having me.